Good afternoon, everyone. My name is Mike Meldrum, President and CEO of the Calgary Health Trust. Really happy to be here with you today, and thank you for joining us as we gather more knowledge on healthcare and talk about some specific items that really impact us here in Calgary. Since COVID has been upon us, there's been a lot of information out there and a lot of information in our community, and it's such a pleasure for us to be able to present such a good quality group today that are going to share and give us some great information that will help us better understand the current situation, and appreciate everyone that's joining us. I'll give some more specific introductions in just a few moments. But we work alongside Alberta Health Services and have been working closely with them to make a number of investments with respect to supporting the COVID response and the pandemic response at this time. If I could get the next slide. And really wanted to recognize many of you are strong supporters of the Calgary Health Trust and Alberta Health Services, and we couldn't do what we do without the support of donors. And our Clean Hands, Giving Hearts campaign has been just a great success as we've gone to our donor community for support, and again, working closely with AHS to make sure those investments are having a real impact and making a difference. Next slide. I wanted to highlight, just before we started, a couple of significant investments that we've made. One of them is a $1.7 million investment, thanks to our donor support, to enhance the testing capacity within Alberta. We know, particularly as we enter the relaunch strategy, that testing is critical. And this investment of $1.7 million is allowing us to really significantly increase, over double the testing capacity in the province, and probably even more importantly, to really shorten the time from test to turnaround, allowing us to get the results more quickly, limit the amount of contact tracing, and really to make the best decisions possible. The other thing I wanted to highlight is another project that we've been able to support, and this is a project that helps inpatients to be able to connect with their families and to better communicate with their physicians using technology, iPads specifically. This has been very challenging times for many of our inpatients that are COVID positive or for other reasons are isolating, and to provide this technology has provided a better experience for them, and so grateful for the many people that have made that possible as well. Just a couple of housekeeping items before we get started. I wanted to introduce Valerie Ball. She's our moderator for today, and so she's on the line and will help us to manage the time and get through this today. We have a number of presenters. One of the things I wanted to highlight is the Q&A feature that allows you to ask questions as we move through. So if you can take note of where that is on your screen, and if you have any questions, and she'll help us to sort of adjudicate those questions and get to as many of them as we can. Finally, just a reminder that we are recording this presentation, and so hopefully on Friday you'll get a copy of this so you can listen to it again if you wish, or to share it with friends or other associates. So just letting you know that we're recording that. So let me, without anything further, just get to introducing our speakers for today. So Dr. Nick Etches is the acting lead medical officer of health for the Alberta Health Services Calgary Zone. And I'm grateful for him to join us today. And he completed his residency and training in public health and preventative medicine in 2014 and has been working with the Calgary Zone since that time. Next is Michael Suddes and Carmella Steinke. Michael is the site director at the Foothills, and Carmella is the executive director of integrated quality management for the Calgary Zone. Also joining us, we have Shawna Syverson and Holly Mackin. Shawna is the senior operating officer at the Foothills Medical Center, and a position she's held for 10 years. And then Holly Mackin is the executive director, surgery, trauma services, and critical care, and the Southern Alberta Organ and Tissue Donation Program. And then finally, Dr. Elizabeth MacKay, who is the facility medical director at the Peter Lougheed, is joining us to talk about ambulatory care and the relaunch. So without anything further, I'm going to turn it over to Dr. Nick Etches to lead us through our first presentation.
Thanks very much, Mike. So I think the focus of my presentation is going to be overall what we're doing around COVID-19 control, what we've done, and the important role that some of the investments and gifts from the Calgary Health Trust have played. Next slide, please. So overall, when we think about the pillars of our response, one of those things is physical distancing measures. The terms lockdown and relaunch are things that we're all familiar with at this time. We also, need to detect disease as much and as quickly as possible. So our testing is a critical piece. And then what we do once we know of a positive test result is important. So, and that's disease control. So I'll be going over all of these different areas. Next slide, please. So these are figures, again, that most people are probably familiar with around flattening the curve. And so the potential for a wave of COVID is in red, and healthcare system capacity is across the dotted line going across. And so what we want to do with all of these measures is to change the red curve into the clear curve, which is below our healthcare system capacity. And so far in Alberta, we've been quite successful in doing that, thankfully, and need to continue to work to make sure that stays the same. Next slide, please. This is overall what our positive test counts have looked like over time in Alberta. Starting on the left there is March 15th, and then to the right is after May 24th. And so you can see we saw a peak of cases in late April and early May, and that has subsequently decreased to current day. Next slide, please. So physical distancing measures. Next slide. So again, this is the first pillar of our COVID-19 control strategy. Next slide, please. So basically in Alberta, we've done a few things, or quite a few things around closing certain businesses, restaurants, schools, restricting gatherings to less than 15 people, broad guidance around, you need to stay 2 meters away from everyone else. And that's very jurisdiction by jurisdiction. But what's really important around these measures is that we also did them early. If you look at it in relation to the number of cases, the amount of disease we had circulating in the community, we did this very early in Alberta, and that's probably a large part of why we were able to avoid some of the very intense COVID peaks that other jurisdictions have seen. But this comes with very significant economic and social costs, as we're all aware. And so there's been some concern around this approach about, the cost of it. And so this is contrasted with jurisdiction like Sweden, and there's been a lot of, media about this that many people may have seen. And in Sweden, they took a more relaxed approach to lockdown. And, they didn't close restaurants and businesses and elementary schools, for example. Next slide, please. And so what they saw in Sweden was they had twice as many cases per capita as we had here in Alberta. This is probably a significant underestimate, actually, based on what I'll show you in the next slide. Next slide, please. And they had 12 times as many deaths per capita in Sweden. So, they didn't have as many restrictions, but based on this, that may have had an effect on, on what they saw COVID-wise in Sweden. Next slide, please. And so recently, actually, the head of the public health agency in Sweden has suggested that they may do things differently moving forward. This is not to criticize Sweden's approach. We were all dealing with a lot of unknowns at the beginning, but just to highlight the importance and the necessity, really, of many of the measures we've taken here in Alberta. Next slide, please. So in terms of relaunch, there's a few key things that we will be watching, or more specifically that Alberta Health and Dr. Hinshaw will be watching. One is the percentage of tests that are positive. The absolute number of positive tests can vary depending on how many tests we do, but the percentage of tests that are positive gives us an idea of how much disease is circulating in the community. The other things that we look at are really hospitalizations and ICU admission rates. These are very robust indicators that tell us what's happening in the community, but they also do lag a bit by up to a week or two, because it takes, for someone who gets COVID and gets sick enough to go to hospital, typically that takes about a week. So the percentage positivity is a bit of an earlier indicator, but these are all things that Alberta Health will be watching very closely. Next slide, please. And so if you look at our test positivity rate in Alberta over time, so on the left is March 6th, on the right is June 6th. And if you look at the blue line, you can see that it peaked again in late April, early May at just above 8%. But now our percentage positivity rate for our tests is reassuringly low for the time being. Next slide, please. And you can see the same thing for hospitalizations in orange and ICU admissions in pink, and how those have reached a peak in late April, early May, and have subsequently decreased. But again, we do expect this decrease to lag a little bit behind what we've seen in our case counts and our percent positivity rate. Next slide, please. And so specifically looking at Calgary zone, this is our hospitalization rate. The line that I'd like you to focus on is the pink line, and you can see again here, late April, early May was the peak, and our hospitalization rate in Calgary zone has decreased substantially since that time. Next slide, please. And so we're in stage 1 of relaunch, moving into stage 2 shortly. And again, these are all of the indicators that we'll be looking at really closely, or that Alberta Health will be looking at as we move through those stages. Next slide, please. So testing and contact tracing. Next slide. So again, this is around, when we talk about testing, we're talking about disease detection. Now, why this is important is in a perfect world, which doesn't exist, we would know every single Albertan who's infected with COVID the minute that they are infected. And obviously this is not possible. This would require us to test every single person in Alberta every day. And obviously that's not a reality. But the point is that the volume of testing we do and how quickly those tests come back is really important. Next slide, please. And the better we do with testing and contact tracing and outbreak management, the less we need to rely on more blunt and broad physical distancing measures. And this is really important, obviously, in terms of because of the social and economic cost of those distancing measures. So testing and contact tracing is really important overall in Alberta, not just for health, but also for the economy. Next slide, please. This is the number of tests that we've done over time. And so you can see that the test volumes that ramped up very quickly beginning in mid-March and have been sustained at a fairly high level since that time. Next slide, please. And so again, I'd just like to express my gratitude to Calgary Health Trust for this investment gift that is really going to help us to make sure that we have the capacity to test everyone that we need to moving forward and detect disease as quickly as possible. Next slide, please. And so disease control. So what do we do when we find a case? And so, one of the most important things we do is we contact that case. We let them know that they were diagnosed with COVID-19. We ask them how they're feeling. And we move very quickly into telling them what they need to do in order to isolate, to protect others. And then also to find out everyone that they've been in contact with during their infectious period to make sure that they are aware that they need to be quarantining to protect others and also to offer them testing. And then when we detect outbreaks, we manage those as well. Next slide, please. So why do we contact trace? Next slide. This is a paper that was published at the end of April from the Lancet, which it shows is a study that was done in Shenzhen, China, which is this is not ground zero for COVID-19. This is not Hubei province, but it is a jurisdiction within China where they compared what happened with people who were detected as having COVID-19 based on contact tracing versus those that were detected just because they got sick and were tested. And this really highlights the importance of contact tracing. So next slide, please. So I'll walk us through this figure. So on the bottom, you have days after symptom onset, so 0 to 20 there. And then on the vertical axis, you can see what's called the proportion confirmed by RT-PCR. So basically the proportion that test positive. So this figure shows how long did it take people to get a positive test after they develop symptoms. The curve on the left with the blue around it is folks that were detected because they were contact traced, and on the right with the purple, it's people that were detected because they developed symptoms and were not part of contact tracing. And so what you can see here on this figure is that people identified through contact tracing were diagnosed more quickly, several days more quickly than people that were diagnosed just because they developed symptoms. Next slide, please. And so what you can see here is as well, this is the same figure except for hospital admissions. And so you can what this figure shows is that for people that needed to be hospitalized because of their COVID disease, they were hospitalized more quickly if they were detected through contact tracing than again if it was just through routine screening measures. Next slide, please. and then this one, from a public health perspective, is probably the most important. This one shows how long it took people to be isolated. And so again, this really shows that folks that are detected through contact tracing are isolated more quickly after they developed disease. This is really important because this reduces the amount of time that people spend infectious in the community and can really help reduce ongoing transmission of COVID. Next slide, please. And these are the conclusions of the paper, which broadly speaking are what I've just articulated to you. Next slide, please. So I want to say thank you as well to the Calgary Health Trust at this juncture. So when we initially had the rapid increase in cases in Calgary zone, there was a risk that we were not going to be able to do the contact tracing for all of them. This is very resource labor intensive work. Thankfully we had a lot of volunteers initially from the medical school at the University of Calgary and subsequently from the U of A Medical School as well. And the Calgary Health Trust, this is maybe not well known, but donated a bunch of meals or money to purchase meals for this team. So it was really nice for these volunteers to have their time and effort acknowledged by coffee and breakfast every morning and lunch and dinner every day. And this team was operating day and through the day and late into the evening. And so just really grateful for that. It had a big impact on our team. And so this is just a picture of the contact tracing team as it was set up at the Sheldon Schumer. Next slide, please. And same here as well. Next slide. And I just really briefly as well plug the contact tracing app that Alberta has released. Alberta is one of the first jurisdictions in Canada to come out with one of these. This is really important, especially as we move into relaunch, because you may not know everyone that you've been in contact with, and this allows us to almost instantaneously notify close contacts of their close contact status and reduce the amount of time that they're infectious in the community. But it only works if uptake is high. If only 20% of people have this, it's not very useful, but it could be very powerful if we can get high enough uptake. So this is just a plug. Next slide, please. This is just a plug for you to, encourage your family and friends and colleagues to download the app. This will help us out from a public health perspective. Next slide here. Outbreak management. Next slide. So, we've obviously been very concerned about the outbreaks that we've seen, particularly in meat processing facilities and long-term care facilities, and then we'll be looking closely at schools and daycares moving forward. Next slide. So this is a picture of Cargill before COVID happened, and so you can see why this is a very high risk for spread. You have people that are standing very not physically distant for long periods of time, and so we ended up seeing over 900 cases at Cargill, and this, as you can see here, is why this is such a high risk setting for transmission. And since that time, not just at Cargill, but at many meat processing facilities across the province, the processes and procedures are very different. People are not as close together, and where physical distancing isn't possible, they're masking, they've got plexiglass barriers and so on. Next slide, please. And this is the team that we put together to manage the Cargill outbreak. And one of the main things that we learned from this is that in order to have someone self-isolate, you really have to provide them support to do so. You have to provide them information in the right language that explains to them why they need to self-isolate. You need to provide them with a source of income, food, cleaning supplies, medical care. And if they're in a large household where they can't be physically distant from others, they need somewhere else where they can stay. And so this group worked to provide all those things to family members and Cargill cases. I think maybe I'm noticing that I'm at time now, so I'll skip the rest of the presentation, but happy to answer questions later. Thanks for your time.
Great, thank you, Dr. Etches. We'll move on to Carmella Steinke and Michael Suddes presenting on COVID capacity response plan.
Great, thank you very much. You can change to the next slide. So first, you're going to get a lot of thank yous today, and thank you on behalf of Michael and I and our entire COVID capacity team, one for being here today, the other for the donation, but also, as Dr. Etches showed us, that we saw a real flattening in the curve in Alberta, and that took all of us distancing and doing the right things. And so thank you for everything that you would have done as an Albertan as well. Next slide. Dr. Etches talked about the flattening the curves, and I won't speak to that part specifically, But what we want to talk about very briefly is what we did as an organization to prepare our healthcare system to have the capacity within ICU and inpatient to be able to respond to that. And it's quite complicated. You can see all the bullet points on the right-hand side. Yes, it is about intensive care unit space and ventilators, which got a lot of attention. It's also about making sure we have enough space in our acute inpatient, but it's mental health, it's also community, it's rural, it's ensuring we have the equipment for that, it's ensuring we have the PPE for staff, it's ensuring we actually have staff and physicians to provide that care. It's about monitoring and being able to respond quickly and using our early warning system. And it's around the morale and keeping everybody going and much, much more. So it's much more complicated than just identifying spaces for our system. Next slide. To do this work, our team took a very systems perspective. You'll see in the center of this diagram, we have what a lot of people think about when we think about what does the COVID capacity response look like, and that's having space in our emergency departments and our acute, urban, inpatient and critical care. But it really takes the entire system around that working together to create that capacity. So that involves partners in primary care, involves community, it involves our continuing care spaces. It involved the assessment networks that were set up. It includes Rapid and 811, as well as our partners in rural. So it's really around understanding how all of these pieces come together and work together for us to create that capacity that was really needed. And with that, it's the capacity, but it's also things like our supplies and equipment, ensuring the workforce planning, analytics, and as well as equipment and beds. Next slide, please. When we took this approach, we worked very closely with our sites and our programs to identify additional capacity that we could bring on board in a very stepwise fashion as we required it. And through that work, we identified over 1,400 inpatient beds dedicated to COVID that we could find within the Calgary zone. And we did that through a four-phase approach that we'll show here in a second slide. The target that we received from ECC, so that's the Emergency Command Center for the province, was about 1,000 inpatient beds that we needed to be prepared for in Calgary with a stretch target of 1,400. And through the work that we did in a very short period of time, we had 5 days that we pulled the team together, we were able to find those spaces and beyond. Next slide, please. This just gives you a snapshot of our original response and how we did that. So we worked and found additional space within our urban emerge, rural emerge, our inpatient units in both urban and rural centers, critical care, mental health, and we were able to identify how we could bring those spaces on additional capacity as required through different stages of a response. So we're not opening up beds and capacity until we need that. And then we also work closely with community and primary care of how they could also help support and allow us to decant patients out of our acute urban sites so that we could free up space for COVID patients. Next slide.
Thanks, Carm. We'll, in the final few slides, give you a sense of what the occupancy of the hospitals in Calgary has been like and then what our next steps would be. In terms of occupancy, Nick showed some slides indicating that the peak COVID case count was around the 23rd of April, and then the hospitalization rate peaked a few days after that around the 28th of April. Our peak occupancy in terms of people in acute hospital beds in Calgary was around the start of May. That was about 50 inpatients and 18 ICU patients. We're seeing, as Nick referenced to, a slow decline away from that descent, and our ICU numbers showed 2 interesting small peaks, and that may be what we see going forward too. We don't see a steady increase, but we may see some small bursts in demand increases. Thanks, Meg. So if we are traversing away from this peak, traversing across the peak and then descending away from the peak, what does that look like? Well, it will require us to provide care for a small amount of COVID-related demand. You're going to hear from 3 excellent speakers shortly about the surgical and ambulatory care return to normal services. But it is going to see us requiring to respond to an increased demand for acute care, mental health services, and others too. And a number of people have been staying away from our hospitals and facilities, including emergency departments. And so we can imagine that some of those people at least will be returning, and maybe returning in less timely fashion, and maybe returning less well as a result of that. And also we can anticipate a fairly significant increase in mental health and addictions demand, and that would be driven by stress, by economic situations, and by addictions and homelessness. You know, we're learning I think well that you don't have to be infected by COVID to be affected by COVID. And so we're preparing ourselves for increasing demands across a range of different types. Thanks, Meg. So as Carm was referencing, our previous demand for acute inpatient care was about 1,400 beds in the zone. The new provincial target for acute inpatient beds is 500, and that sees Calgary chipping in with about 188 inpatient beds. So these are COVID dedicated vacant beds or beds that are ready to be occupied within 24 to 48 hours. And again, very happy to say that the plan is in place for all of those beds and more, and that plan has been achieved on a unit by unit, site by site basis. Thank you. Thanks, Meg. Just to give you a sense of that returning demand by way of some data slides, on the left you see the urban acute emergency department trends in volume, and then on the right you see the occupancy of our acute urban adult hospitals. Yesterday we saw about 800 adults in Calgary urban emergency departments, and today our occupancy in adult urban acute hospitals was about 97%. So both are showing really steady increases from that initial dip in activity associated with the first few weeks of the COVID response, and all of our demand is really back to sort of seasonal or maybe even a little higher than seasonal levels. Thanks, Mike. It's been a really phenomenal collaboration in the planning and execution of our COVID response, and we don't want to miss a single ounce of the lessons that we learned from that, and we also don't want to sort of waste a crisis in that regard too. So the leadership who are responsible for managing capacity across the zone and patient flow and access to services are keen to support all of our efforts around transitioning into our new normal, but taking the lessons learned from that to help us with that. So we already have booked a system-wide summit event, which will help us understand what are the things that we did that worked really well that we want to keep doing, what are the things that show promise and we would like to grow and do more of in the future, and what are some of the things that we stopped doing that we want to keep stopped and never do again. And so that very real link between the COVID response and that enhanced collaboration and what we do in the next 12 months around getting patients into services as quickly as we can and transition them through our care will be very tangible and be well informed by the COVID response. Thanks. Final slide now, Meg. And again, just wanted to thank, we owe a huge debt of thanks to our direct care providers and our acute care and rural and mental health and community facilities, our physicians and nurses and allied health and clerical staff and leadership staff too. But this slide just shows you some of the faces of people who work in other services too. So people who work in supplies, people who work in transition services, people who work in analytics. And as you saw from Nick and some of Cam's slides too, that tracking of how things are going with really good access to good data in a timely manner has been extremely important. And then our public health teams and our health link teams, as well as our supplies team at the bottom. So as well as our direct care providers, this has been a huge and well integrated and collaborative effort involving a whole range of different stakeholders. And we did want to take the opportunity to thank them for that too. Thanks, Val.
Great. Thank you so much, Michael and Carmella. We'll move over to Shawna Syverson and Holly Mackie. They're going to talk a little bit about getting back to normal, specifically looking at our surgical response.
Thanks so much for the opportunity to present on the surgery relaunch this afternoon. So just wanted to start off, next slide please, with an overview of surgery pre-COVID in the Calgary zone just briefly. We have 5 acute sites, including 1 pediatric site. We have 3 rural sites in Calgary, 1 in High River, Canmore, and Banff, and a total of 77 funded ORs. There's also a large amount of surgical activity that occurs in the chartered surgical facilities. Last year in the Calgary zone, there was a total of 103,416 surgeries. And where we have 77 ORs, the development of the shelled ORs on the 5th floor in MacKay at the Foothills Medical Center remain a high priority for future growth and expansion. Our last surgery uplifts occurred in 2018 and 19, where we saw an increase to our cancer and cardiac surgeries in the Calgary zone. Next slide, please. There are a number of surgical advancements and improvements that we're quite proud of pre-COVID, such as the use of minimally invasive surgical techniques in cardiac, spinal, plastic, and gynecological surgery. These techniques limit the size and number of incisions. Work has also been done to increase the utilization of our rural OR capacity, where we have moved out general surgery and peripheral vascular day surgeries from our acute urban sites to rural locations. We've also begun work in the last several years at 2 of our sites to start to implement our early recovery after surgery, or ERAS pathway, which addresses optimization pre-surgery, as well as aspects of care intra and post-operatively. And these have expanded since and include areas such as colorectal, breast, head and neck, gynecological, gyne-oncology, and hepatobiliary. With the spread of this initiative across several surgical specialties and sites, it's reduced our length of stay and ultimately our use of surgical inpatient beds, which frees up our bed capacity for improved patient flow. Other surgical specialties have undertaken initiatives to also reduce length of stay, some examples of those being direct anterior arthroplasty and other quality improvements in orthotrauma, general surgery, and thoracic surgery. Next slide, please. Pre-COVID, provincially, the good news was that there was a great deal of work that had been done on the Alberta Surgical Initiative to address the growing demand for surgery with an aging population. And based on that need, a 4-year plan had been approved to improve access to surgical care, where more scheduled surgeries would be done, including those within the clinically recommended timelines by 2023. This 4-year plan was a phased approach that would have started this fiscal year in 2020-21, including a number of strategies that spanned the patient's surgical journey, such as specialist advice to referring family physicians prior to referral for surgery, improvements in the provision of surgical consultation and recovery, and coordination and development of additional surgical pathways for patients referred for surgery. The ASI included an expansion of surgery at all sites, as well as a move of less acute surgeries out of our urban sites to increase access to meet the demand for more complex and major surgeries in our urban sites. The approval for this plan came in the fall of 2019 and was to start, as I mentioned, this fiscal year. However, it was put on hold due to COVID. Next slide, please. So on March 18th, surgery was reduced to scheduled, urgent, and emergencies only. So this included non-scheduled emergency surgery, scheduled surgeries for cancer, obstetrics, and those with an urgency of 7 days or less. With this reduction, we were operating at 34% of our normal surgical activity in the month of April compared to last year at the same time. With this reduction in scheduled surgeries, ambulatory visits were also reduced to urgent only. So this too has contributed to a backlog in demand for scheduled surgery with the resumption of our surgical services. As of the end of May, approximately 8,700 patients had their scheduled surgeries postponed due to COVID. And with our surgical resumption that started in early May with day surgery and then expanding to 24-hour and inpatient surgeries, about 40% of those surgeries have since been completed, and there's still about 60% remaining to be rescheduled. Next slide, please. Just to give you an idea of our surgical wait list for scheduled surgery pre-COVID, there were about 32,560 people waiting in April 2019, with approximately 60% in window, compared to April 2020, where this wait list has now is just over 35,000, which is a 7% increase on the wait list, with a reduced number waiting in window that's fallen down to 41%. For those with cancer, we've seen an increase in our cancer cases being completed in April 2020 compared to 2019, as well as an increase in the surgeries completed within their target window. That's risen up to 76% compared to 67% at the same time last year. Next slide, please. The surgery recovery plan for the first 6 weeks was approved and started on May 4th with day surgery with an expansion to the inpatient surgery requiring an overnight stay, and that started on May 24th. And within that, the first 4 weeks, we saw approximately 900 cases rescheduled. And a provincial plan is under development for a stage approach to surgery recovery beyond those first 6 weeks. Next slide, please. With the surgery recovery plan beyond the first 6 weeks, it's projected we need to increase our surgeries where we've got additional OR capacity during the weekdays and then potentially after hours when we reach the fall and winter months of this year. So while we move through our surgery recovery, we still need to hold OR capacity for any COVID emergency surgeries that might be required. And as part of our surgery recovery planning, we'll also be working to align with some of the principles from the ASI plan that remain a high priority, such as virtual support for family physicians and central intake. And within the surgery recovery, we also, and needing to address the backlog post-COVID, we expect to have some emerging needs for specialty items or additional equipment. And so you can just switch to the next slide, please. So the ASI plan between years 1 and 4 had earmarked a need for $42 million in minor equipment and $46 million in capital equipment within the Calgary zone. And that included a build out of 3 shelled ORs on the 5th floor in MacKay at the Foothills Medical Center. And so some examples of our areas of greatest needs that we anticipate in the Calgary zone include things such as the laparoscopic imaging package, video integration for ORs to support general surgery and plastics, a Da Vinci robot for urology, additional microscope and a laser for cancer and plastic surgery, OR tables across orthopedic, orthotrauma, and spine surgery, and additional diagnostic equipment, primarily C-arms for orthopedic, neurosurgery, and spinal surgery. I'll just move to the next slide, please.
Hello, everyone. I hope you can hear me. This is Shawna. I'm just going to talk a little bit about next steps for the surgery expansion. So many of you would have heard the Premier and the Minister and their interest in growing the private provider publicly funded surgical services. Many of you might also know that Calgary Zone for over 20 years has delivered surgical services in non-hospital surgical facilities, and we want to grow that as much as we can. So the theory around this is we'd shift a lot of these procedures we're currently doing in the hospitals outside of the hospitals so that we could backfill in the hospitals those types of procedures that could only be done in a hospital setting. So you'll see that we do over 25,000 contracted surgeries per year now, which is a large number. In addition to that, we do another 5,500 in the women's health sphere at Kensington Clinic. And so over 30,000, but we're looking to grow that and to expand it. Currently, we do ophthalmology, dermatology, oral max, peds dentistry, and podiatry, and women's health. But we would like to grow that, and the minister was really challenging us to think around orthopedics, gynae surgery, and plastic surgery. So you'll start to see as we are doing this resumption plan that concurrently we're going to endeavor to try to grow some of the surgical services we provide outside of the hospital setting as part of this growth in the ASI plan. So just thought, I know that's top of mind for some of the people listening in. Lastly, just in closing, wanted to say a real special thanks to the Calgary Health Trust for their approval of the ultraviolet lights that we installed in our COVID dedicated unit here at Foothills Medical Center. We're currently doing evaluation and research on the efficacy, but it's been it was a huge bonus, such a swift approval, and we think has made a real difference to our patients. So thank you very much.
Thank you, Shawna and Holly. And we're going to wrap up with Dr. Elizabeth MacKay, who's going to take us through the plan for ambulatory care and how we're going to move forward for the province or for.
Thanks very much for allowing this discussion. I will start by just describing where we went through the ambulatory working group and how that helped support some of the ambulatory work across the COVID pandemic as well as part of the relaunch. When we knew from a public health order that we had to limit all ambulatory visits to include only those that were urgent or emergent, it was important for us to identify ways to still provide some supports for patients across the continuum. So a group in the zone was put together that allowed for the creation of an ambulatory incident management team with representatives from all the sites and programs, including rural and community. And that group provided some coordination of that ambulatory care, developing pathways to allow for a reduction in visits, but also safety and allowing for those visits to occur with the appropriate spaces, patient flow screening, as well as testing requirements. And then also develop specific communication process for how folks would access resources that traditionally would have been either associated with acute care or at least available in the community, lab, DI, and specialized testing. And then lastly, the ability to get personal protective equipment for care providers that were providing ambulatory care in the community needed a ways to be able to access and understand what those pathways would look like. Next slide, please. One of the hugest pieces to this work was the understanding of how virtual care had to play a much bigger role, both during the pandemic and in the relaunch. If you look at just on a given site, they would have up more than 100,000 ambulatory visits on a site that during the COVID, during the pandemic itself, we were seeing that reduced by 50 to 75%. And of those that were remaining in that urgent emergent sphere, 85% of them overall were virtual, with only 15% of them being face-to-face. Obviously different across the different areas depending on whether or not those were procedures involved. But it certainly suggests a huge amount of activity that was shifting to a completely different sphere. Next slide, please. Virtual health, which had been gradually evolving, and we knew that technology was helping us in a variety of areas, but virtual health itself, the care provision when the provider and recipient are separated by location can be done in a variety of ways using virtual innovations and technology, and in particular allow for supporting both access but quality and efficiency, but need to actually be done correctly and evolve. We had to do it very quickly. Next slide, please. There were a number of COVID-19 examples of virtual health that were supported in a variety of ways across the system, such as ID specialists being able to consult on COVID cases, family medicine clinics allowing for vulnerable patients to be visited via home, mostly by telephone on the short end, but with increasing amounts of use of Zoom or other technologies, and assessment centers. But there was in the background a virtual hospital work that had been going on in Edmonton and Calgary, and that obviously was lifted up a bit to allow for looking at more home monitoring and using expanded technologies to help do that monitoring in the home setting. Next slide, please. The next steps as it relates to virtual health were certainly to be able to expand the capacity and ability of the virtual hospital type methodologies where it's a little bit more intensive with this remote physiologic monitoring, but also expanding how Zoom is used across a variety of AHS and contracted provider settings. And in particular, needing to look at expanding some resources to support both clinical workflow as well as multidisciplinary teams, as well as how do we help patients to use these sorts of resources. Next slide, please. The other huge piece of the work in the ambulatory sphere that wasn't well visualized was how allowing for specialists and primary care integration was lifted by COVID. The example I'll use is Specialist Link. It's the Calgary Zone Primary Care Network and Specialist Communication method, where at the time that the COVID was occurring, they had around 20 specialty areas that would link directly with primary care. As you can see on this slide, during COVID, they were able to add an additional 20 specialty areas to Specialist Link across different areas. And that led to what you can see across the volumes of Specialist Link calls doubling over the time period that the COVID pandemic occurred. Where a lot more patients where normally you would be able to get a referral because they were looking at central access and triage, focusing just on urgent or emergent cases, there still needed to be a way for patients and primary care medical home to be able to connect on cases, and they would do so via Specialist Link calls in addition to e-referral or e-advice type of methodologies. And this certainly expanded across the pandemic. Next slide, please. The referral pathways, including that central access, needed to be more nimble and flexible to be able to respond to changes in COVID by phase, as well as access to where those assessments could occur, and onboarding of a number of practitioners to help to do that work. Next slide, please. So the virtual health program within AHS has been developing a number of tools and supports and educational opportunities for different care teams to be able to learn about how to incorporate Zoom and other methods into the virtual health realm as we move forward. Next slide, please. In addition, as patients were not coming to centers, virtual health also meant that we would have to develop better strategies for communication ongoing, as in having resources and educational documents available where patients and families could be pointed to access those resources. Example here of some GI and hepatology links that can be given through a virtual means. Next slide, please. As we're now preparing for relaunch, there's been a number of areas that need ongoing support as ambulatory clinics and community and acute care sites are starting to increase the volume of patients that come through. And while we need to continue with identifying and screening, we need to continue with reducing the number of services that need to come on site and maximizing use of virtual services appropriately, as well as develop pathways for patients to be able to move through these areas with social distancing, as well as have access to personal protective equipment for patient staff moving through those areas, as well as an ability to provide ongoing supports for communication and integration of activities into the primary care home, enhancing those communication methods. Next slide, please. So what's required and what the ask would be to help support this initiatives as we move through next phases of increasing the number of patients who are going to be seen in ambulatory care centers. We certainly do need ongoing support for the evolution of virtual care. That may be the technologies of cameras and headsets and monitoring devices, but also an ability to actually monitor and evaluate that we're doing this well, so that when we implement bigger systems like Connect Care across the Calgary zone in the next few years, that we will ensure that these are embedded in a way that allows us to maximize their use. The second piece is we've understood that there's a need to look at different way to support both patients and practitioners with virtual care navigators, as well as community healthcare workers who can help folks to manage when we're doing more distance activities. Thirdly is an understanding that language services was really important during the pandemic, and we were able to develop strategies for patients and families to be able to communicate, but also for healthcare teams to be able to get some language services brought into healthcare. We don't quite have a way yet to integrate those together moving forward with virtual care, and certainly we will need to have some support for developing that. As mentioned as well, the web resources and patient education forums and pathways that have to exist in a way that people can access and have the privacy and other legal requirements embedded needs ongoing development. I did mention already the specialist link and its ability to onboard access to referrals, as well as central access and triage, and tools for patients and practitioners in the community to be able to manage patients while waiting to get access to next levels of care. That will need ongoing development, as some of those teams who just came on board are really just getting a good understanding of how central access and triage might help them. That leads obviously to our ongoing work with the PCNs in trying to do the primary care integration work and being able to help the teams to strategize on how they can ensure that the right work is being done in the medical home and helping to reduce demand for services by maintaining as much as possible in the medical care home. And lastly, I think we did learn a lot about how having to just do what was required to try and reduce the impact and exposure of patients and healthcare practitioners showed us that we could work smartly on how to integrate some of those learnings into more choosing wisely as we relaunch into access to lab, diagnostic imaging, and specialized testing can be informed by the work that occurred across the COVID pandemic. I will stop there and say again, very thankful for the ability to demonstrate all of the great work that was occurring from a number of groups needing to collaborate in ways that they weren't doing in the past, and that we're hoping that this will afford us some opportunities in how to transform the system in the future, but as well and ensuring that everybody is getting an opportunity to ensure that we are providing that key communications across the continuum, so that we can make sure that we do not have folks who are limited in their ability to access because of the way the system had to remain so nimble to manage COVID. I'll stop there, and I know we're going to open things up to allow for the answering of the questions.
Perfect. Thank you so much, Dr. MacKay. I think we gave everyone a very tall order to cover such a broad topic in a very short amount of time. So really appreciate how each of you have approached your presentation and been able to share some really great information. I'll just start, just because it's top of mind, with ambulatory care and some of the things that Carmella and Michael discussed with capacity. We talked a little bit about anticipating the need for increased capacity around mental health. Do you believe that there has been some forced accelerated innovation that could potentially help with this capacity, as you're talking about virtual visits? And what are some of those key things that you think will stay with the health system to help address some of the capacity requirements?
I'm not sure who you would like to answer that question, but I can maybe start, and then Dr. MacKay, do you want to answer? On one of our slides there, that's what Michael was referring to. What we want to do as part of our going forward is really understanding what we learned well as a system and what we really should continue. There's some things that we changed in the way we provided care, or the way we were able to identify capacity in our system, that we're kind of forced to do that because of in response to the pandemic. But there's some really good learnings that we're going to try to capture that and then push those forward. Dr. MacKay, I'll let you answer more specifically about ambulatory.
I think within the mental health arena, it was clear that it was uncertain how to provide support in the community in a way that allowed for the especially vulnerable populations to get access in an equitable way. There needs to be some understanding of how having teams work together to provide more of that wraparound care would allow for a better solution than a standard way that we were having patients access the system in usual way. So I think some of the learnings we had, where we were able to quickly put together a team, such as what was described, I think Dr. Etches described around the Cargill response, was what I think a huge learning around how to enhance the capacity of the system in the community to wrap around and provide care in a culturally sensitive as well as vulnerable sector, understanding of how patients' needs can be met, rather than trying to sort of suggest that we would stick to traditional types of access and spaces that would be required. So example of that, ACES Hotel providing some isolation spaces in an area where they were able to then provide some harm reduction strategies and social supports that were required, rather than having patients come and stay on an acute care that wouldn't be able to be responsive to those needs. So for sure, that's the type of learnings that I think when we move forward in understanding how being both flexible, but also creating a space and supports that go to the patients, rather than trying to suggest that they need to come in through traditional means, is important.
Thank you very much. The next question is for Dr. Etches. Dr. Etches, there's been some conversations about masks, and that conversation has evolved, of course, over the course of the COVID pandemic. It's been suggested that maybe early on being able to identify masks and wearing masks could have prevented some increase in our outcomes. What are your thoughts on that?
Yeah, it's a good question. I think there's a few things that I would highlight in response to that. Number one is, I think the evidence around masks in COVID-19 will continue to evolve, and I know that Alberta Health and Dr. Hinjal will continue to pay really close attention to that. Generally speaking, masks are not a substitute for physical distancing, and I think this was one of the concerns initially. Is if would there be a sense of complacency generated by mask wearing, and we know that transmission can still, masks are not perfect, and especially if you're talking about non-medical masks, there's evidence that there's quite a lot of variability in terms of the effectiveness of those masks to actually screen out viral particles, for example. And we know that where we have continuous masking in many of our facilities, infections can still happen. So, unfortunately, it's not a perfect intervention. Having said that, masks do have their role when you're unable to maintain that 2 meters of physical distancing. So, I hear the question around, there is, with the physical distancing measures, there are costs to that approach. But I think masks are something we need to continue to look really closely at. I think the reality as well at the beginning is just that there's, the availability of medical masks was, and non-medical masks for that matter, was quite limited. And so, I don't know whether or not that would have been feasible at the beginning of COVID-19. And then as well, there's population acceptability and compliance. If you make mask wearing, mandatory, how do you enforce that? And then as well, we know that some of the transmission, the highest risk transmission settings are indoors, households, and transportation. And I think it would be, again, very difficult to ensure compliance at that level. But it's a good question, and again, something that we will always continue to pay attention to the evidence that emerges in that area.
In your presentation, you talked about being able to potentially lessen social distancing measures that needed to be taken. What considerations are put into place in order to be able to actually start to move closer to each other, I guess?
Yeah, and again, this is so important because physical social connection is important to all of us, and it's a big part of health. I think the issue right now is that as long as we don't have a vaccine, everyone who's not got COVID in the population, which is the vast majority of people, is still susceptible. And so, physical distancing measures, until we have a way to, again, provide immunity through a vaccine, physical distancing measures are going to be part of our lives. In terms of the overall relaxation of restrictions, that's currently occurring. And testing will help us to keep a close eye on what's happening and to do case and contact investigation. But I don't anticipate that it will, be open season in terms of physical distancing anytime soon, unfortunately.
Thank you. I'm going to ask one last question and then I'm going to turn it over to Mike. The 65 plus generation is obviously some of the highest risk population. Is there anything that they should be considering as we start to open up Alberta and open up our hospitals? Just, obviously keeping in mind that there is the risk of the spread of this virus as we open things up a little bit.
So I can, if it's okay, take the first run at that one. I think that, generally speaking, we're talking about the over 65 demographic. When continuing care homes, we have, very, very stringent criteria and operational procedures that the staff and residents there have to follow. But then, for folks that are not in those environments, the best way that we can protect that demographic, first of all, is to have a low level of overall population spread of COVID. That's number one. And so far, I think in Alberta right now, we have relatively low case volumes, which is important. And then I think, really what we're encouraging people to do is, to continue to keep 2 meters away from others, to, not have large gatherings, particularly indoors. And those would apply to this demographic as well. And I think as well, there have been some earlier on in COVID-19, there were some, for example, grocery stores that had specific hours where where seniors could go during that time and not be exposed to as many individuals. I think that was really good. But I think in general, our recommendations have been for this demographic to really stringently pay attention to the guidelines that exist, and some additional messaging around, for example, not providing childcare when daycares close. We were recommending against that just because of the potential for spread there. But generally speaking, if individuals if everyone does their part, this is going to be the part that protects our seniors the most. And then again, if seniors pay really close attention to the guidelines that exist, they'll be able to protect themselves further that way.
Great, thank you very much. I'm going to turn it over to our CEO, Mike Meldrum, to close us out. And thank you all to the speakers for joining us today in the excellent presentation. Mike, please go ahead.
All right, thank you. I did want to just thank Valerie for moderating. I would also like to thank all of you for joining us, and a special thank you to all of our presenters that have just given us great insight to how our community and how the healthcare system has been able to respond to the COVID pandemic. I think it's impressive, the planning that goes into this, and the outcomes have been impressive as well, as people have followed the different guidelines, and as we have continue to have the health system working despite the pandemic. So I wanted to just remind people that this will be sent to them via email. Again, thank you to everyone that joined us today, and very grateful for the community and how it's been pulled together, and the long-standing support of each of you in the philanthropic community. So thank you for joining us today, and have a great rest of your day.